Shall we make a start? Okay, so this afternoon the next two talks are going to be on non-invasive ventilation, and I'm going to start the ball rolling. So I'm going to break my talk up this afternoon into a couple of sections. How did we get to where we are today? So in other words, a little bit of the history of neonatal ventilation and how we became interested in non-invasive ventilation. I'm going to talk a little bit about CPAP in the delivery room, and then CPAP in the intensive care unit, and finally something that we've just recently finished is a study of high flow subnasal cannulae. So in the beginning, one of George Simbruner's mentors was so concerned about the bad results that people were getting when they tried to ventilate a baby in the way that we do today through an endotracheal tube with intermittent positive pressure ventilation. He was so concerned about the bad outcomes, mainly these babies just died, that he thought it was worth trying another way. And for little babies, that is less than 1,500 grams, he tried CPAP. Initially delivered through an endotracheal tube, and this was his landmark article published in the New England Journal of Medicine in 1971, and this was groundbreaking stuff. This was a report of only 20 babies in this very low birth weight range. Some babies down below a kilo. 930 grams was the smallest, and what he found was when he treated babies like this, they didn't all die, and that was something of a breakthrough. Some of these babies would survive, just breathing for themselves, breathing through predominantly an endotracheal tube. And this was his device, a pressure source coming from an anaesthetic bag, and a manometer measuring the pressure, and he was delivering pressures that were quite high by today's standard, up to 15 centimetres of water, and that was what he used. Of course, that device had the problem of still being a long tube through the delicate mucosa of the baby's upper airways, and still problems associated with that. So he went on to develop some alternate devices, ones that didn't need the endotracheal tube, like the Gregory box, which you can see here. Fairly cumbersome looking instrument by today's standards, and you can imagine it would be very difficult to get access to the baby's face and yet maintain pressures. But nevertheless, it was this device and other devices that started us becoming interested and delivering effective non-invasive ventilation. And that was going on through the early 1970s, but it came to a dead stop. People stopped becoming interested in non-invasive ventilation because better ventilators were developed, more appropriate to the size of the babies that we were looking after. We became better at driving those ventilators. We developed skills and knowledge about how to use this new technology and maintain babies on an endotracheal tube. And then, to some extent, the death knell of non-invasive ventilation was surfactant. Everybody was very excited about surfactant. You could give surfactant, open the lungs up, and avoid a lot of the damage that was previously associated with endotracheal intubation. So for those reasons, people forgot about non-invasive ventilation and concentrated on intermittent positive pressure ventilation. This is a quote from the late 80s, which sort of encapsulated what neonatologists' attitudes were at that stage. Intubation and intermittent positive pressure ventilation should be used routinely on all extremely low birth weight neonates, should be started as soon as the infant is on the resuscitation trolley. And that was what I was taught to believe when I was a registrar. The best time to pass an endotracheal tube was as soon as the baby was born. Well, it was still too stunned to fight you. Get that endotracheal tube down. You're the doctor. You're in charge. You'll look after this baby best with an endotracheal tube. But somewhere in this big swing towards intubation and ventilation, this study was done. And this is a comparison. I guess most people have seen this slide before, but this is a comparison of 8 North American units, and you can see the blue bars are the survival rates in each of those units, very similar, all around 80%. The pink bars, though, are the rates of chronic lung disease. And you can see there is one unit number 3, that had a far lower incidence of chronic lung disease than any of the other North American units. And of course, you all know that this is Columbia University Hospital in New York, where they used a lot of CPAP. And so in that one small part of the world, the spirit of non-invasive ventilation was kept alive. There were enthusiasts who did it well, who developed skills in looking after babies on non-invasive ventilation, and they were delivering better results. And so people started to become interested again in non-invasive ventilation. I just put this slide up again. I showed it yesterday, and just another reason why it's worth letting babies determine how much respiratory support they need. And just to refresh your memories, this table shows that for babies under 1 kilo, the vast majority breathe. 80% of these babies breathe, and roughly 70% of them cry. So they're capable of opening their own lungs, they're capable of breathing for themselves, and perhaps they just need a little bit of help from us in the form of CPAP. And so relatively recently in terms of the overall history of neonatal intensive care, we've seen at least 3 large randomised trials that have attempted to answer the question, what is the role of CPAP in the delivery room? And we'll go through these briefly. The 3 big trials, COIN, Support, and the Vermont-Oxford Network trial. So the COIN trial was our trial, and so I know a little bit more about this one than the other trials, but it was the first of the large multi-centred randomised trials, a few more than 600 babies. What we were interested in was babies between 25 and 28 weeks gestation. So the babies that were at high risk of BPD, but the babies that we thought might be able to be managed successfully on nasal CPAP. So the deal was that these babies were delivered, they were given a little bit of, a few puffs of positive pressure ventilation if they required it, and if they were then breathing adequately but still needing some respiratory support, then they were randomised. The envelope was opened and they either got endotracheal tube or nasal CPAP, and all this happened in the first 5 minutes of life. And the primary outcome of this study was the combined outcome of death or bronchopulmonary dysplasia. The results of COIN disappointed some people, but were nevertheless very interesting. This is a sort of I'm not sure how this translates into Polish, but we have an expression, is the glass half full or half empty? So if you're a half full person, you're an optimistic person, and I'm an optimistic person, and I would say that half the babies who are managed with nasal CPAP in the delivery room were never intubated, never saw an endotracheal tube. There was a trend towards better outcomes at 36 weeks for the CPAP group, a trend towards less bronchopulmonary dysplasia, less time on respiratory support. They certainly spent less time on an endotracheal tube, as you would hope and expect. The downside of the babies managed with CPAP is that they had more pneumothoraces, a rate of 9% in the CPAP group versus 3% in those who were intubated, and that was a major concern for many people. No differences in any of the other neonatal morbidities. In fact, trends towards reduction in rates of intraventricular hemorrhage and other important outcomes. So at the end of the COIN trial, we concluded that infants in this gestational age window who breathe at birth, so they had some respiratory effort but they needed some support, they could be managed with CPAP and had some improved outcomes compared with those intubated and ventilated from birth. So that was COIN, and next came the support trial run by Neil Feiner in California, a very big trial, 1,300 babies, multi-centred randomised trial, extended down a little bit lower in terms of gestational age, down to 24 weeks. These babies were randomised before birth, so the envelope was opened before the baby was known to be a baby who breathed or would perhaps automatically need an endotracheal tube to save its life in those first few minutes of life. But beyond that, this trial was very similar to COIN. Babies randomised to CPAP, or the endotracheal tube. Those who got an endotracheal tube were given surfactant within the first hour of life. And again, the primary outcome was death or BPD. Very similar results in support to COIN, although there was this trend towards reduction in BPD with the CPAP group. It didn't reach statistical significance, and the bottom line was there was no difference in death or BPD. But the babies were less frequently intubated in the CPAP group. They received less steroids for BPD, probably an important clinical outcome. Fewer days on a mechanical ventilator, and importantly and somewhat reassuringly, no difference in the rate of air leak, roughly 7% in each group. Most recently has been the Vermont-Oxford network trial, published now 2 years ago, another big multi-centred trial, slightly bigger babies, 26 to 30 weeks gestation, and this was a 3-armed randomised trial. So one group was intubated, received prophylactic surfactant. The second group was intubated, surfactant, immediate extubation, and then the third group bubble CPAP between 5 and 7 centimetres of water, and then selective intubation and surfactant for babies who are failing CPAP. Again, primary outcome, death or BPD. The Vermont trial struggled with recruitment, particularly towards the end, and stopped early at 648 babies. Again, no significant differences in the primary or secondary outcomes. Again, a reassuring similarity in the pneumothorax rates between the two groups. And a very similar result to COIN. Almost 50% of the CPAP group never intubated, and slightly more than 50% never given surfactant. The conclusions from the VON trial, the authors said, well, there seemed to be no negative effect of applying elective early CPAP to these infants. It may be recommended as the less invasive and potentially less expensive method. So in other words, if there were no big differences between the groups, you'd go for the simpler, less expensive method. So we all have to come up with our own responses to this accumulation of evidence. I'd be very interested in the question time to hear others' responses, but this is what I think. I like nasal CPAP. I think it's a perfectly appropriate first-line treatment for babies in the delivery room, for preterm babies, and you saw the video yesterday of how we apply it to even our smallest babies now. What's changed in my practice in reaction, particularly to that higher pneumothorax rate in the COIN trial, was that I tend to rescue babies earlier. So babies who are starting to fail on CPAP, rather than let them get to 60% oxygen, which was what we did in the COIN trial, we let their CPAP pressures drift up to 9 or 10 centimetres of water. By the time the baby gets to 40% and a CPAP of 8, I'd say, right, this baby's got moderate hyaline membrane disease, let's intubate it, give him surfactant, and then take the tube out as soon as possible. I don't have any evidence to back that up. That's just merely my reading of the evidence, and as I say, I'd be interested in hearing others' opinions. It was hoped that CPAP would be the magic bullet. If we avoided intubation, then BPD would go away, and clearly that hasn't happened. If you put all the trials together, you see a small but significant reduction in BPD over all these trials, but it's certainly not a magic bullet, and research needs to continue into ways of reducing BPD. it raises a few questions. We know CPAP is as good and perhaps a little bit better than intubation. We know that surfactant really works very well. If you've got an endotracheal tube, you should give surfactant fairly quickly after that endotracheal tube goes down. But there are risks of intubating a baby, so it'd be wonderful if we could combine CPAP and surfactant without needing to pass an endotracheal tube. And so that's been the focus of our research in recent months and years. That shows up okay without the lights going down, is that right? So this is a new way of delivering surfactant to little babies. And what we're using here is a vascular catheter. It's an adult vascular catheter. You can see it's we use it, pass it through the vocal cords, squeeze the surfactant in, remove the tube, and then the baby goes back onto, in this case, mask CPAP. I'm going to do now is show you a newer video. You notice that time we'd taken the prongs out before we delivered the surfactant. We've moved on and are now applying this technique to babies remaining on CPAP. So this baby's still on CPAP, tube goes in. We're now giving the surfactant, trying to time it with the baby's breathing. That's very difficult and not always possible, but giving it in small boluses, trying to coordinate them with the baby's breathing efforts so the baby inhales the surfactant. Okay, so the baby tolerated that very well. In Europe, in Germany, you will have been aware of the work of Angela Krebs, who's used a similar technique, but using a feeding tube, which is a much more floppy tube, and it requires forceps to pass it through the vocal cords. This technique's got the advantage of being stiff enough so that you don't need forceps. We think probably less intrusive on the baby, less annoying to the baby. So that is a potential way of combining the benefits of CPAP and surfactant that we're currently investigating. Okay, so having said that 50% of babies on CPAP never get an endotracheal tube, well, 50% do get an endotracheal tube, and then our job is to get them off as quickly and as safely as possible. It's clear that nasal CPAP is a very useful treatment for getting babies off an endotracheal tube. This is the pooled analysis, and I don't think there are likely to be any more randomised trials in this area, but after about 9 trials, the pooled analysis, the red diamond at the bottom, well to the left of the line of no effect, favours nasal CPAP. If you treat 6 babies, you'll prevent 1 baby needing to go back on the ventilator. So nasal CPAP, very good way of preventing re-intubation. But I think, as most of you know, CPAP is not without its complications. And just as Andreas yesterday was showing some of the bad things that happens at his unit, here are some of the bad things that happen at my unit. This is a baby who's obviously had some trauma as a result of his nasal CPAP, some damage to the nasal septum. Very difficult to get the right size prongs. They're often too small, and you have a big leak around the prongs, and that means that the pressure is difficult to deliver. If you try and go large with the prongs, it can cause trauma, and we see some blanching of the skin around the nose. These prongs are fairly primitive devices. Babies have triangular nostrils. We're putting round prongs in them. babies are active, they move around, so we can have the prongs in perfect position 1 minute and 30 seconds later they're either out completely or they're pressing on the nasal septum or the wall of the nose, and now you've got a big leak as well. So that's what's led us and others to consider the use of high-flow subnasal cannulae as an alternative to CPAP for supporting little babies. And the reason why this has become an interesting issue and a very popular way of supporting babies is sort of obvious from this slide. So babies with CPAP, and everybody's got a different way of applying them, but they all, to some extent, resemble a medieval instrument of torture. This baby does not look terribly comfortable. Whereas the high-flow nasal cannulae are lighter, easier to apply, and for that reason, I think, a lot more popular. These are the two devices that we have available to us in Australia. We have the Vapotherm and the Fisher and Paykel device. I'd be interested to know who is using high flow amongst the audience. Can I have a show of hands? Who uses high flow? Who doesn't use high flow? Oh, that's good. I was afraid everyone was asleep, but okay. So the majority of units in Europe, is that right? Are not using high flow? Yeah. Okay. So that's good. So this is what high flow looks like. The prongs hanging loosely around the cheeks. We've got some duoderm protecting the cheeks. The prongs are well away from the nasal septum, and there's a big leak around the nostrils and also around the mouth. So a different way of getting gas into these babies. How does it work? Well, that's not clear, but these are some theories. The most accepted way that high-flow nasal cannulae work is by delivering, like CPAP, positive distending pressure, but it's not being set or monitored like a CPAP device. So you're not dialing up a pressure, you're dialing up a flow to go into the baby, but you you don't know exactly what CPAP pressure is delivering even at the upper airway. It certainly delivers oxygen and at much higher concentrations than low flow nasal cannulae. The big difference is that this gas is heated and humidified. That we say that that's conditioning of the gases, and if you talk to adults who've had these prongs up their nose, they'll say that to breathe heated and humidified gas, even if it's just air, is a much more comfortable experience than unhumidified gases. One other theory is that it works by supporting inspiration. You've got a very high flow, somewhere around 6, 7, 8 litres per minute going in, and that's supporting inspiration, reducing the work of breathing. Maybe it's just washing out. They've got a big leak, so 7 or 8 litres going in the nose and just continually washing out the dead space of the upper airways, preventing rebreathing, and maybe that leads to better or more efficient ventilation. So a number of proposed mechanisms why high flow might work. But if you tell doctors you're delivering a pressure, but we're not actually sure how much pressure we're delivering, and you're doing this to babies who we know are prone to pneumothoraces, there will be concern about that unpredictable distending pressure. How much? Well, there's some data that comes from small observational studies, some crossover studies, some animal studies, and all of them have got varying ways of estimating pressures. But the bottom line is that where people have been able to measure the pressure, usually in the esophagus, that's generated by high flow, it's less than or almost equal to the pressures that are being delivered with nasal CPAP. And this is some work from my colleagues in Melbourne. Flow through the cannulae on the x-axis, pressures delivered, measured in the esophagus, in the pharynx, mean pharyngeal pressure. So at flows of 2 litres per minute, we're getting around 2 centimetres of pressure. Going up in proportion to the flow, when we get to 7 litres, we're getting about 7 centimetres of pressure. At 8, still slightly less than 7 centimetres of pressure. So delivering pressures that are in the same ballpark as those we're used to when we deliver CPAP. The other thing that this group did was just measure the difference that happened when the mouth was left open or passive, and when it was closed. Some small differences, but not huge. So who's using it? Internationally, in the US, it's really swept the country. 2/3 of US academic units, so university units, are now using high flow, and that was in a survey in 2010. In the United Kingdom, even higher uptake, more than 80% of UK units are using it. And even in the smaller units, and this is perhaps a little bit worrying, the level 2 or the regional units, 50% are using them. 1/3 of level 1 units, these are the most basic, provide the most basic level of care in the United Kingdom, using high flow. So it's a treatment that's out there, and it's become very popular, at least in the US and the UK. And these days, when we go to America and we talk to the doctors there, some of them will say, our unit doesn't use CPAP anymore. We're so comfortable using high flow, we no longer need nasal CPAP. So why is this so? Well, the reasons are largely anecdotal, and when people survey, and this is we've done this ourselves, say, why are you using CPAP? Well, it's easy to use. It's safe. Well, the perception is it's safe. Decreases the work of breathing. Most importantly, the nurses love it. Right? It's much easier to look after a baby on high flow than it is on nasal CPAP. The prongs don't slip out. They don't get malpositioned. They say the babies are more settled. Less CPAP belly, less nasal trauma, no pneumothoraces. So all anecdotes. But when you go and look for hard evidence, as the authors of this Cochrane review did, very little around, insufficient evidence to establish the safety and the effectiveness of high flow in preterm infants. So, being used in 80% of UK units, many US units, not proven to be safe or effective. And of course, the usual Cochrane response is, well, what we need is properly powered randomised trials. And so we took this seriously, and we performed the hyperspace trial. It's a fairly tortured acronym, but picked by one of our science fiction loving fellows. And so the question we asked was, in babies less than 32 weeks gestation, having their first time off an endotracheal tube, we were going to compare high flow, starting at 5 to 6 litres per minute, versus nasal CPAP, starting at 7 centimetres of water. And the primary outcome was failure within 7 days, but we were following these babies until they went home. So the inclusion criteria: babies less than 32 weeks, being ventilated, being extubated for the first time, we needed parental consent. We didn't want babies that had been ventilated for such a long time that they already had BPD by definition, so babies more than 36 weeks were excluded. Babies who were not being fully resuscitated and babies with major anomalies were all excluded. Now, I don't know if you're interested in this, but it was a new concept to me when we first started doing this trial, and we were interested in this study and this treatment, not in the context of whether it was better than CPAP, because there was no real suggestion that it would be more effective at keeping babies off the ventilator. The question was, is it any worse than CPAP? And so this raised the question of non-inferiority trials, which I hadn't been aware of in neonatal intensive care before, because most of our randomised trials are superiority trials. So is high frequency oscillation better than conventional ventilation? Is cooling babies' brains better than not cooling babies' brains. So what a non-inferiority trial tries to determine is the treatment, like high flow, as efficacious or no worse than the standard treatment, which in this case was nasal CPAP. And the premise usually is that the new treatment has some other benefit and might be favoured over the standard treatment, even though the efficacy is the same or maybe not quite as good. And you can see why this might be so for the comparison of high flow. If it was nearly as good as CPAP, but cheaper, easier, more comfortable, then you'd use the high flow. Now, a little bit of science here. It's based on a risk difference, and it's 95% confidence intervals between the two treatments. This becomes more obvious when we show it graphically. What you need to define in these sorts of trials is what sort of margin of non-inferiority that you'll accept. We picked 20%. We said as long as the 95% confidence intervals are less than 20%, clinicians would say, okay, we'll use high flow. So if the risk difference for treatment failure and the upper limit of its 95% confidence interval are less than 20%, then high flow is non-inferior. This becomes a bit easier when we look at a graph. So this is what a conventional risk difference graph looks like. We've got the line of 0 here. To the left, we're going to say high flow is better. To the right, we're going to say high flow is worse. And we're expecting high flow to be maybe not quite as good as nasal CPAP for keeping babies off ventilators. If by some chance the risk difference lay to the left of the line of no effect, then high flow would be superior. We weren't really expecting that to happen. This graph shows what we were testing, that high flow was perhaps a little bit worse than nasal CPAP, but the 95% confidence intervals cross 0 and they don't cross the 20%. Okay, so that was what we were proposing to test. If we had a result that looked like this, so the point estimate or the risk difference was between 0 and 20, the line crossed 0 but also crossed 20, then we could not say that the treatment was non-inferior. This would be an inconclusive result. And finally, if the line, the risk difference and its 95% confidence intervals were to the right of the 20, then it would be clear that high flow was inferior. So we looked at our data and we said, well, our CPAP failure rate is about 25% in this group of babies, and therefore we needed 300 babies to test our hypothesis with 90% power. So we randomised babies just before the tube was to come out. We used the conventional randomisation, wisdom variable block sizes, sealed opaque envelopes. We were interested, we've got babies less than 32 weeks, we're interested particularly in the tiny babies less than 26 weeks, and so we stratified to separate these tiny babies from the bigger babies because we knew that the little babies were more likely to fail. Made sure babies got caffeine before extubation because there's good evidence that that's a good thing to do. High flow babies extubated to 5 to 6 litres per minute, up to 6 to 8 litres per minute and down to 2 litres per minute. So the flow that you use through each of these prongs depends on the size of the prongs, and that is determined by the size of the baby. So for the biggest prongs, you can go up to 8 litres per minute. For the smallest prongs, only 6 litres per minute. We said that if you reached failure criteria and you were randomised to the high flow group, you could use nasal CPAP. So you could rescue babies with nasal CPAP if they'd failed high flow. CPAP, we used either ventilator or bubble CPAP, Hudson prongs. 7 centimetres of water was our starting point. We went to 8 as a maximum. down to 5 as a minimum. People could use non-synchronised NIPPV if they liked, and we discouraged, and in fact we largely prevented any use of high-flow nasal cannulae in the CPAP group. Primary outcome, failure of assigned treatment within 7 days, and that had to be fairly clearly defined. So babies got to the maximum amount of support in each of their groups, and they had one or more of these problems. So their oxygen requirement went up by more than 20% above their pre-extubation rate. The apnea, they had more than 6 apnea events requiring stimulation over 6 hours, or 2 episodes requiring positive pressure ventilation in 24 hours. Respiratory acidosis, or an emergency intubation. So a baby suddenly needs an endotracheal tube. The physician had the discretion to do that. So these were fairly concrete failure criteria. So high-flow babies, if they failed, they could be tried on nasal CPAP. If they failed again, they were reintubated. So they were rescued. Nasal CPAP babies were just reintubated. Okay, this is where I signal the guy in the control room. Thank you very much. We've got to stop taping now because these results are still in the hands of the journal, so we can't. I'm afraid I'm going to have to kill you all once I've told you what the results are. No, just kidding. So this is what our flow chart looked like. Started off with 1,100 babies in that gestational age range. Many of them never ventilated. A few died before extubation. A few other assorted babies were missed. 170, that left us with almost 500 eligible babies. A few were missed, a few declined consent, a few were consented but not randomised. Their tubes came out before people could open the envelope. So eventually we got down to our expected sample size, 150 in each group. So this is just our babies, and they're probably very much like your babies. Gestational age around 27, 28 weeks on average, just over 1 kilo in birth weight, boys and girls roughly split. Got a very high rate of antenatal steroid use in Australia, well above 90%. Most of these little babies are being delivered by a caesarean section, and about 1/3 of them are multiple births. Very evenly matched babies between the trials, between the two groups. About 2/3 of these babies intubated in the delivery room. The overwhelming majority, almost all of them, given surfactant. People were compliant with our request to use caffeine before the tube came out, and we try and get their tubes out very, very early. So the median age at extubation was in the first 2 days of life. So we're very keen to get that tube out. But babies being extubated from fairly low oxygen requirements. So we give the surfactant, the babies come down to air or close to air, and we pull the tube out. And this is the result. So in the high flow group, 34% of the babies failed their treatment in the first 7 days, versus 26% in the CPAP group. That gives us a risk difference of 8% and a confidence interval that goes from -2 to 19%. So that's what this looks like. 8% difference in failure rate, the 95% confidence interval crosses the line of no difference and doesn't quite cross the line of non-inferiority. So by our definition, high flow was non-inferior to nasal CPAP. Now we'll have some questions later on, but I'm sure people will ask, well, what if you chose something different? Why did you choose 20%? So feel free to ask that question later on. For the little babies, what we found was that our failure rates were actually quite high. And there was a difference between high flow and CPAP. The risk difference was 20%, so 81% high flow, 61% failed in nasal CPAP. The confidence intervals look like this. Because there are so few of these babies, this is an inconclusive result. nevertheless, we would look at this, look at these numbers and say, gee, you better be careful using high flow in these tiny babies. The bigger babies, of course, the result was closer together. The difference was only 5%, the confidence intervals, as you see there, and the graph that looks like this. So in the group of larger babies, beyond 26 weeks, we're much more comfortable in saying this high flow is non-inferior to nasal CPAP. So those, just to reiterate, those are our results. Overall, non-inferior, inconclusive, but a little bit scary using high flow in babies less than 26 weeks, and much more confident in using it in the more mature babies. Babies tended to fail early. If they're going to fail, most of them fail in the first day or two. The differences, there were very little difference in the reasons for failure. Apnea by far the most common reason, followed by an increase in oxygen requirement. Clearly you can see that babies could have more than one reason to fail. So what about using nasal CPAP as backup? Okay, so this is the outcome re-intubation. So admitting that babies who'd failed high flow could be rescued with nasal CPAP. The differences went away. In fact, they were reversed. 18% of babies were re-intubated in the high flow group versus 25% in the CPAP group. So the risk difference favours high flow. The 95% confidence intervals still cross the line of no effect. So the message here was, if you're using high flow but you have nasal CPAP available as backup, this is a very reasonable way to manage your babies. So keeping the CPAP as a safety net for babies who fail high flow. Half of the babies who failed high flow were successfully rescued. We're very good at keeping babies off high flow in the nasal CPAP group, so they had no days of high flow. Babies in the high flow group did get some CPAP, but on average they got no CPAP. Other secondary outcomes, I won't go through this in detail, but no difference in rates of death or bronchopulmonary dysplasia or any of the other important outcomes. Certainly no problems with pneumothorax, no difference statistically, only 1% of babies. So that, I think it was just literally one baby in the high flow group developed a pneumothorax. Similarly, the other neonatal outcomes that we're used to, retinopathy of prematurity, ducts, sepsis, neck, perforation, ultrasound abnormalities, not a hint of difference between the two groups. Days in hospital, no difference. Babies gained weight equally in both groups, so no difference in those other important outcomes. But what we did see, and I guess this meant that the popularity was to some extent justified. There was a statistically significant reduction in nasal trauma from the CPAP rate of 55% to high flow 39%. But remembering that many of these babies on high flow were randomised to high flow but actually got CPAP, only 19% got it while they were on high flow. So the difference was clear and substantial. We did some comfort scores. How comfortable were babies on CPAP? We haven't fully analysed this data yet, but it appears that babies are more comfortable on high flow. So we would conclude high flow non-inferior to CPAP. The risk difference was 8%. About half the babies who fail high flow successfully rescued by nasal CPAP. I'd say it's feasible. You can do it in the little babies, but be very careful in those babies born below 26 weeks gestation. No difference in the risks of any other morbidities, and a real benefit in nasal trauma for babies in the high flow group. So, what do we make of all this? Going back to CPAP, CPAP I think is an appropriate first line method of respiratory support for babies with RDS. My criteria for rescuing these babies have come down compared to previous years. High flow nasal cannulae are an acceptable method of post-extubation support, particularly for babies 26 weeks and above. I've raised the question of minimally invasive surfactant treatment. That's it looks like it might be a very nice way of combining the benefits of CPAP and the benefits of surfactant, but this requires a large-scale randomised trial, so we're starting to do that now. And the question is, can we use high flow as first-line treatment for babies with respiratory distress? If we can use it for babies coming off the ventilator, can we use it for babies with moderate hyaline membrane disease? And that's another study that needs to be done. So I'm going to leave it there. If there are any burning questions, we can have them now. Otherwise, we might have questions after Andreas's talk. Tom. You don't.
I'd like to take a moment and not toss it completely off to a subject for another trial, and give your impressions of whether, now that you've seen this data, whether you would expect to see similar data for early first intention with high flow versus CPAP.
Yeah, if I had to guess, I'd say it's probably going to be good for the bigger babies. But the question that we haven't addressed really is the risk of pneumothorax. Babies coming off a ventilator are actually at quite a low risk of pneumothorax. Babies who have got developing hyaline membrane disease are at risk of pneumothorax. So I think I wouldn't be trying it just without a little bit more substantial data to help us. Yeah. Yeah.
Thank you. Would you like to comment on the use of nasal CPAP through a nasal mask instead of prongs, please?
Yep. That's a good question. It's not something we have a lot of experience with. We use nasal masks for babies with trauma to their nose, so to give their nose a rest from the nasal prongs. There is a trial recently published from Ireland that showed that nasal masks were superior to nasal prongs. A fairly small trial and one that needs to be repeated, I think, before we all believe that result. But I think if you're using nasal masks, keep using them. There's some evidence that that's a reasonable thing to do.
It's hard work. Well, as a Scandinavian, I'm very much agree with you in all the nice things you've been talking about, except one thing. And it's not about CPAP, but about giving surfactant without endotracheal intubation. Because you said that the baby looked comfortable. And I'm afraid I have to disagree. He had movements like he was coughing very much. And we know that when we give surfactant to an intubated child, lots of things is going on in the brain. So I would like to ask, how about sedation, not only to reduce pain, but also to reduce the coughing when you give surfactant?
Good question, and a question that was asked before we started. Now, we've now treated roughly 100 babies with this method, and we were expecting our nursing staff, who are very strong advocates for the comfort of babies, to say, no, you can't do this. This is inhumane. The babies are going to suffer. But since we've started, we've not had that problem. Maybe that baby did look a little bit uncomfortable. Our general experience is that the babies tolerate it very well. There is sometimes some reflux of surfactant, as there is with intubated babies, but we're relaxed about giving it without formal sedation. We give the babies glucose, but that's all. There's obviously a trade-off here. If you can do well, we use our best intubators, people who can do it most quickly and most effectively, so that they're doing it in and out before the baby becomes uncomfortable. We're avoiding using the McGill's forceps, which I think make the procedure longer and probably are more uncomfortable. And we're avoiding the risk of sedating the baby to the point where it's going to need intubation and ongoing ventilation. But I take your point that that's a trade-off, but that's how we see the trade-off.
Okay.
Is Andreas?
Excuse me, sir. What about nasal cannula? We use it 2-liter flow in our unit, nasal cannula. We can increase it for 4 or 5, like this high flow subnasal cannula. What is the difference between high flow subnasal cannula and you told high flow nasal cannula?
No difference. I just ask if you're...
We use nasal cannula in a low flow, 2 liter per minute.
Okay. Is it humidified?
No, not a humidified.
Okay.
Just the humidification.
So the difference is, yes, just humidification and heating, and this may be important. When we've tried flows above 1 litre in the past in unhumidified, we find problems with drying out of the nose and nasal trauma. Yeah. Okay. Thanks very much.